So welcome to Fertility Questions to Ask Your OB GYN. I'm Dr. Hal Danzer, one of the co-founders of Southern California Reproductive Center. It was just about 20 years ago, Dr. Suri and I, the other co-founder, had a vision to build out a fertility center that offered the very best in science, to offer our patients the very best in fertility treatments, and also in a caring environment. We've been able to do that over the past 20 years. We probably had more experience in IVF, growing embryos and freezing eggs than any other program in the Los Angeles area. And we've been very happy to be successful in those areas. So presentation today about future fertility, planning for your fertility in the future. I think most of you have gynecologists, and how do you ask your gynecologist about your future fertility? So here's a picture of our center at night. We're on the 5th floor and the 7th floor and the 1st floor. We have a state-of-the-art embryology laboratory, surgery center, and I think we offer the very highest quality laboratory services for the best pregnancy rates for our patients now and in the future. We have built to 6 doctors presently, and maybe 2 more that are just starting. So we've been able to grow, and certainly fertility services are in great demand for a lot of reasons we'll talk about through the program. And the picture on the left shows our in vitro fertilization laboratory. We do about 1,500 IVF cycles. About 300 of those are egg freeze, and the other are creating embryos for future transfer. So we're essentially the largest laboratory in the Los Angeles area. And on the right side is just our operating room where we retrieve eggs and do other procedures to offer the very most up-to-date treatments for fertility. Here's a little picture of somebody placing vials of eggs into a cryo tank, which is liquid nitrogen, and we'll talk about that later on too. But this kind of lists the things that we do in our laboratory, time-lapse imaging of embryo growth. It's a very new technology that we offer patients, and we'll talk about that a little bit later in terms of talking about embryos versus eggs. So today I thought I'd start with a story. Everybody likes a story, but these are stories that came to me just in the last few months. A couple that called, a man and woman, 34 and 35 years of age. They were both in their own separate startups for work, and they weren't planning on being able to start a family for 3, maybe 4 years. So she would be in the late 30s, which can be sometimes problematic in terms of getting pregnant. And so they had questions about whether to freeze eggs or freeze embryos. And we'll talk about that later on, and the difference between the two and the advantages. Another woman called me. She was 32 years old, had just been to her gynecologist, who had done a blood test called AMH, anti-Müllerian hormone, and a follicle count. And her gynecologist had called back and said, gee, I think you have a low egg reserve, and referred me to get information about possibly freezing my eggs. So we'll review that with the other part of the discussion. And then the third call, which is probably the most upsetting, was a woman that was 35, and her birthday was the next day, and she just ended a 4-year relationship. And the couple had broken up, and part of it was because they were getting to the point where they were talking about having a family. And she was a family of 3 children, and 1 and 2, maybe 3 kids. He was from a family where there's a lot of dysfunction, and he was the only child and wasn't so sure that he wanted to have children. So that was part of the reason for the breakup. But so she was facing starting a new relationship at 36 years old, and it takes several years to build a relationship to even talk about having a family. And then by then you're in the late 30s. And what does that mean in terms of my fertility? what is the best way to go? So these are kind of three stories that feed into what we're going to talk about today in terms of fertility preservation. So part of the first question is, how many kids do you want, and when would you like to have them? And again, couples say, well, I think we want 2, but we're not sure about 1 or even 3 with the cost of education today. And you can't know that. Obviously, as you move through life and you have the first child, you don't know about whether you're going to want 2 or 3, and we can't know the future, unfortunately. So starting out, how do we get an idea about one's fertility in the future? And we have 2 tests now that are in the past few years have really give us great insight into a woman's future fertility. And essentially, they're assessing one's egg reserve. And we'll talk about that in just a minute. But the first blood test is anti-Müllerian hormone, AMH. And it's a simple blood test that can be done with the gynecologist. Any commercial lab will do AMH. And the other is an ultrasound, which essentially counts the numbers of follicles or eggs that are recruited for a given cycle. And again, both of those combined together give you a sense of one's future of fertility. We have many questions about health conditions that may affect fertility. Some medications, some women that are on anti-inflammatories, rheumatoid arthritis or lupus, psoriasis, is that going to affect my future fertility? Can I take a woman trying to get pregnant? Do I have to delay getting pregnant because I have to get off these medications? Part of the evaluation is how regular are cycles. Women that have irregular cycles are not ovulating regularly and may take treatment to induce the ovulation so that they have a chance to get pregnant in the future. And again, if it looks like there's going to be some difficulties in the future, one would look at egg or embryo preservation as early in their history as they can. Family history can be important. A mother that had early menopause, and that's menopause under the age of 40, that sometimes runs in family and be an important piece of information. That woman would want to have an AMH and a follicle count, probably in her early 30s. So many women are diagnosed with polycystic ovarian syndrome. And these are women that have irregular cycles and have many follicles. They also may struggle with the quality of their ovulation. And again, they would be candidates to look to preserve eggs or embryos for the future. Some women are diagnosed with endometriosis, which, painful periods, which may cause scar tissue and may really diminish your ability to get pregnant quickly in the late 30s. Thyroid disorders, a previous history of pelvic infection, STDs. And then you have a partner that may have difficulty with sperm count. He may have some medical issues or family issues that may come into play in terms of future fertility. So those are all things that, again, would ask your gynecologist about. And he might have the history for you of your cycles and whether you might be PCO or do you have a history of endometriosis. So those are, again, questions that your gynecologist could answer for you, that if you are somehow at risk for fertility in the future, then you want to get a plan to preserve eggs or embryos. The big question today, do I need to get vaccinations? I think everybody wants to try to get vaccinated today. Certainly the recommendations from the CDC and the OB GYN societies that if you're thinking about getting pregnant, you'd like to have the vaccination, because we know that during pregnancy, the infection can be more severe. So why do women freeze their eggs? And obviously it's to preserve their fertility if they're not planning on starting their family till later in life. The ideal time we'll come into in a minute, but we'll go to the next slide and you'll see how a woman's eggs diminish. Now, sperm are made every day. They're kind of brand new, but unfortunately, whoever designed the system for women and it was probably to protect women from having pregnancies later in life. You're born with maybe 1 million eggs. By the time of puberty, there's about 40,000 eggs left, maybe 30,000, depending on who you read. But that egg reserve begins to diminish over the reproductive years. And some women at age 31, 32 have a low AMH and a low egg reserve, and that tells you they very possibly are going to struggle to have pregnancies in their late 30s. So that's why this diminution of eggs is, and we have nothing, people ask about medications or a particular diet that's going to save their egg reserve, and we don't have that today. And we know that some women lose their eggs more quickly than others. And everything about our body is genetics. It's probably somewhere on the X chromosome for the woman. And some women are just going to lose their egg supply at a faster rate than others. So today, with the technology, we can try to identify those women that are going to have that diminished egg reserve in their mid to late 30s when they want to start their family. The other thing that we clearly know, and you can see from the graph, that as a woman diminishes her egg supply up through the late 30s and early 40s, the genetics, the normal genetics of the egg diminishes also. And that's so important. We talk about the genetics of the chromosomes, the 23 chromosome pairs, they get kind of sticky with the egg, don't separate cleanly. So when they're fertilized with a sperm, they have an unbalanced genetic pair. And that increases pregnancy or decreases pregnancy rates and increases miscarriages. So again, being able to preserve eggs at an earlier age, they have a much better genetic normalcy. So we have a lot of questions about, well, I think I want to freeze my egg, but how do I get prepared? And people ask about diet. I think a Mediterranean diet is something we all recommend just for general health, to prepare for a pregnancy, but also prepare for any sort of IVF cycle. And they talk about high vegetable protein and good fiber and low sugar. It's different for every individual in terms of what's the best nutrition for them. We have on-site nutritionists to help to guide people in terms of reviewing what their nutrition is and what they could do to make it just better in terms of their general body health. But we don't have a magic food. People always ask about what the magic food is, and I say, well, chocolate chip cookies. The things to avoid when you get ready to get pregnant or freeze eggs or embryos, you have to really drop back to alcohol, maybe drink a glass of wine once or twice a week. People ask about cannabis. We don't have a lot of long-term studies, but I think we like to eliminate any chemicals. People ask about supplements and other herbal agents. We don't have a lot of science to tell us about those agents, and therefore the general recommendation is to try to not have any foreign substances, have good nutrition. And then certainly smoking, we know nicotine causes vasoconstriction, limits some blood flow to the ovary. And there's many studies that show that there's decreased fertility in women who smoke. So those are three things that you can do to get prepared for the very best cycle for eggs or embryos. So the next big question once you get prepared is, what is the process and how long does it take? And generally when we start from, I'll show you on the next slide, that we usually start off, it's about a 4-week process. And on the start of the cycle is the first day of the period. We usually use birth control pills for about 2 weeks to get the ovary quiet, synchronize the follicles, and then we start a stimulation with injections of follicle stimulator. And it takes about 12 days to mature an egg. So 2 weeks on the pill, 2 weeks on the stimulator, and then at that 4-week time is when we do what they call the egg retrieval. And then that day that we retrieve the eggs, if you freeze the eggs, they're frozen exactly on that day. So everybody wants to plan their cycle. When your period starts, it's about 4.5 weeks later, the actual retrieval. So we come back again to ovarian evaluation, and we talked about how you do this basal follicle count. And with ultrasound, you can actually count the numbers of resting follicles in an ovary, what you have to work with and what you have to stimulate in a given cycle. The ultrasound also looks at the other physical characteristics of the uterus and the pelvis. So that's all part of the diagnostic testing we do in the very beginning. So now we come back to the testing of anti-Müllerian hormone, AMH. And you can Google AMH and they'll show you this graph and describe really what the test looks for. But AMH, this anti-Müllerian hormone, is made by each of the thousands of follicles in the ovary. Now the follicle is a little ball of cells that encases a single egg. So there's one egg in each follicle. There's no double yolks. So if this graph actually illustrates whether you're in the high, medium, or low range. And again, with the basal follicle count, it tells us about what type of stimulation, how aggressive the stimulation might need to be to get 15 to 20 eggs for an egg-free cycle. And that's our goal because that usually translates to about an 80–85% chance of at least one full-term pregnancy. You say, wow, 20 eggs, you only get one baby. There's a lot of fallout. Eggs don't all thaw, they don't all fertilize. And embryos that are created in the laboratory, half of those stop growing because of genetic remix issues. Again, we know there's thousands and thousands of genetic pieces that have to rearrange from the sperm and the egg. And Mother Nature gets that rearrangement right. Maybe 1 in 4 embryos when you're young, and maybe 1 in 6 or 8 when you're in the late 30s, early 40s. So our goal is about 15 to 20 eggs. Now, some women have a big egg supply and they get 25 or 30 in a given cycle. There's some women that may only get 8 or 10 eggs in a given stimulation because that is their reserve. And they may do 2 or sometimes 3 cycles to get a sufficient number of eggs for the future, depending on how many kids they think they want to have for their family. So this is a nice ultrasound picture of an ovary that a woman's been on birth control pills to synchronize the follicle. And the ovary is about the size of your thumb. And you can see those little dark areas are actually follicles. They're about 10 millimeters. And there's a microscopic egg on the edge of each one of those follicles. But what we have to do, again, once we get the ovary quiet, then you have to wake the ovary up to mature the eggs. And that takes about 10 to 12 days of injection of follicle stimulating hormone, which is a natural follicle stimulator. It's been used for over 30 years. It's very safe. There's no cancer. There's no early menopause. These 15 or 20 follicles come up every month, but normally only one egg is released and the other follicles dissolve, and the woman starts with a new group the next month. And again, that's how the eggs reserve diminishes as you're using 15, 20, sometimes 30 eggs in a given month cycle, but only one egg is released. And this kind of shows the progression of what the ovary was like when you start. And then with the stimulation of the injection of the follicle stimulator, now we've got 15 to 20 follicles that are measurable. And we know with the size of these follicles, now there's a mature egg on the wall. And the last panel shows a little needle coming in at the 11 o'clock position to aspirate the fluid. And again, this aspiration is done under a very light anesthetic, propofol, which they usually use for dental work. It takes about 15 to 20 minutes to retrieve eggs. There's very little recovery. Most are able to leave within an hour and a half after the procedure. And Tylenol is really all that's necessary for a little bit of analgesia. And most people go back to work the next day. So it's a simple procedure. It's certainly very safe. But again, advancing that needle into one follicle, then the next and the next, taking the fluid, which is then passed right into the next room where the embryology lab is. And the embryologist then takes the microscopic egg from the fluid. And this next picture you see on the right, that's the human egg. and that's the largest cell in the body. And we know that all cells are about 60, 75% of water. And that's why it took so long to develop the technology to dehydrate the human egg, because it's such a large cell with so much water. You can't really freeze and thaw an egg well unless you dehydrate it, because the water inside the cell then crystallizes and can damage the egg. So today, the thaw rate for frozen eggs is about 80 to 90% in our laboratory. So that technology is very much improved than what it was 10 years ago, when maybe half of the eggs would survive the freeze and thaw. So the technology has marched on and really allows us very good recovery of frozen eggs. Just kind of a side note, you can see on that little video how a sperm is placed in the egg after it's thawed. When the woman, the couple, decides that they want to create a pregnancy, one sperm is placed in each egg, and you have to inject the sperm into the egg because thawed eggs tend to have a much thicker outer coating. But again, injecting the sperm is standard for almost all IVF, does not damage the egg, and certainly doesn't have anything to do with the genetics of the egg or the embryo. But fertilization rates are at about 75% with the injection of the sperm. But again, it's a very safe technology today. It allows fertilization to occur at an almost normal rate. So one of the questions we always get is, well, how many eggs do I need? Again, you see from the graph that the cumulative live birth rates increase with the number of eggs. And again, it has a little bit of age effect before 35 and over 36, because again, as the egg reserve begins to diminish in the late 30s, the genetics of the egg begins to diminish also. So if you're in late 30s, early 40s, a lot of times when they say, well, I need 20 or 30 eggs really to give me the best chance of pregnancy in the future. So how do you start your fertility journey? Here's our 6 physicians here at SCRC. And those of you that would be interested in going forward or have questions, I think we could begin that and answer any questions you might have about freezing eggs or making embryos for the future. So I see there's 2 questions coming up now. Let me see if I can. So we have a question here about actively trying to get pregnant now with my first child. I don't see an age here, but if you're in your mid-30s and you say, well, I want to have a chance for 2 or 3 or maybe 4 kids, would I freeze my eggs? And this is the question we came up to before, is that if you have a partner, making embryos is the preferred way to go. So you get the egg, you fertilize the egg, and you can grow the egg to an embryo to 5 days. And then at that point, you can genetically test the embryo. A genetically tested embryo, the pregnancy rates are close to 80%. So, and also, gender, if you want to balance your family. So freezing the eggs is probably, unless you're planning on getting another partner, you'd like to use your present partner to make embryos. I hope that answers the question. Is taking prenatal vitamins a good idea before trying to get pregnant? Yeah, absolutely. We usually recommend start at least a month or 2 before you want to attempt pregnancy. Senior gynecologist doing a thyroid function test and vitamin D. Those are 2 screening tests that are important. And also they usually test for whether you have immunity to rubella, chickenpox. Some women lose their immunity, and there's a standard panel that is done in blood test, genetic screening for cystic fibrosis and Tay-Sachs. So you definitely want to talk to your gynecologist planning to get pregnant in the future. to begin to look at that testing, along with your AMH and basal follicle count. I see Lauren says, is there an age cutoff for freezing eggs? Yes and no. Obviously like to freeze eggs in the early 30s because genetically they're more likely to be balanced. By the time you get to the late 30s, early 40s, maybe 1 in 4 eggs is going to be genetically balanced. We have women that say, well, I'm 42 and I don't have my partner yet and I want to freeze my eggs. And there's some women at 41, 42 that have a really good egg reserve. Again, the goal would be 15 to 20, but if you're over 40, if you can get more than 20 eggs would be ideal. So I don't think we've really frozen eggs for women much past 43 because, then it's maybe 1 in 8 or 10 eggs that would be genetically balanced. And then another question is, what's the best age to test my fertility? And I think starting in the early 30s, that's when you begin to have this question for your gynecologist and say, I don't have a partner yet, and I'm just building my business, or I'm still in school, and I don't think I can start a family for another 3, 4, 5 years. So what's my AMH going to be, and what's my basal follicle count? And again, AMHs can be done yearly. You might have a great follicle count and a very high AMH, but if it begins to diminish a year or 2 later, then that would be the signal to consider freezing eggs. But today the guidelines are, if you can make a decision to freeze eggs, the early 30s is really the best time. We've seen some women in their late 20s also. We know that freezing eggs in the late 30s and early 40s just is less productive in terms of finding that genetically good egg and eventually embryo. Trying to scroll down here to could you go back to how many eggs you need? I froze at looks like 33 and have 35 over 4 freezes. Okay, so you were doing maybe 8 or 7 or 8 per cycle. Now I'm 40 and want to start the process. What are the percentage rates for using younger age, but now 40 for implantation? Well, the issue of freezing eggs at 33 and 35, the eggs are always 33. They're always genetically the same. Again, if you're going to start your family at age 40, say egg thaw rates are generally in the 80 to 90% range in most of the good laboratories. Fertilization rates are maybe 75%. And then of those that fertilize, maybe half make it to embryos. And again, at age 33, about 60% of tested embryos would be generally normal as far as their genetic balance. So I think you've probably got a good number. And people say, well, should I freeze or thaw half of the eggs and save half? I think generally you want to thaw all the eggs because there's such an attrition rate, and really look to see what you have as embryos and genetically balanced embryos after the thaw and fertilization. Now, some people say, well, do I have to do genetic testing? You don't have to. We know that pregnancy rates with untested embryos, when you transfer the embryo, is maybe 50%, whereas a genetically balanced embryo, the pregnancy rates are close to 80%, with a very low miscarriage rate of about 8%, as opposed to 15% of untested embryo. So Stephanie is asking, do you recommend I go straight to IVF if I've had 4 ectopic pregnancies, lost 1 fallopian tube, and I'm 31? Well, if you have a partner to make embryos, I mean, that's ideal. Again, if you've had many ectopics, I don't think you want to get pregnant on your own. Risk of other ectopics is huge. So yeah, I think you'd be a candidate for IVF. And again, to do that at the earliest age, the more embryos, and especially if you make embryos and you know what you have as far as genetically balanced embryo, again, that pregnancy rate is 75 to 80% for each transfer of one embryo. So yeah, I would think if you're ready to think about getting pregnant even years from now, you would go ahead and make the embryos at 30, 31. That's the very best time. And I have a question, does IVF help when a man has low motility? Yeah, it certainly does. Motility is the most important part of sperm function. The sperm has to find the egg. It can't see it. It almost has to pump into it. And then it has to burrow through that outer coating. And that takes very good motility to do that. So when you do IVF and you have eggs in the laboratory, if the motility is low, then the ICSI procedure, intracellular sperm injection, is really the cure for that, because they take a look and they find the best looking sperm, has the best shape, and they inject that single sperm. And again, fertilization rates are 75 to 80% with ICSI. So ICSI has been, in IVF, has really been the sort of the cure for men with lower sperm counts. So here's a question about how would you approach treating someone with polycystic ovary and improving their chances for a live birth? So many women with polycystic ovary are skipping cycles. They don't ovulate regularly. And fertility agents have been the first treatment option. Clomid, Femara are oral agents that help to increase one's FSH, because the problem with PCO is the woman's follicle stimulator from the brain is at very low level. So if you can stimulate that with oral agents, or sometimes you have to use the injectable FSH, but almost always you can induce ovulation. And women with PCO have big reserve, and almost all can be as successful. Again, but you want to get started to your early to mid 30s. Oh, we have a lot of questions here. Alicia, what is the approximate total time from the initial consultation to implantation if you choose to do IVF? So again, when you start an IVF cycle, there's initial evaluation, but at the start of the next period, there's that 2 weeks of birth control pills to get the ovary quiet, synchronize the follicles. And then the injections start and eggs are retrieved about 2 weeks after that. So now you're at the 4-week mark. When you make embryos and genetically test them, you have the results about a week later. But embryos are then frozen and you let the body recover from all the stimulation. So implantation or transfer of the embryo is 6 weeks after the retrieval. So it's 4 weeks and 6 weeks is the total time to being pregnant. So is it better to do the AMH test with by OB GYN or a fertility clinic? Certainly you can do it with your OB GYN. I think AMH is out, and I don't know, the insurance coverage is getting a little bit better, but it's about a $150 test. It's not huge. I tell many women, I think that AMH is probably more important than a Pap test. Once a woman has 2 normal Pap smears in a row, her risk of having an abnormal is very, very low. And if, instead of the cost of the Pap test for the next GYN visit, get an AMH. I think if the AMH is on the low range, that's when you would have a consultation with a fertility specialist. There are some OB-GYNs that do basal follicle counts. Not all are trained in that way, but that's done at the beginning of the cycle, day 2 or day 3. And again, to look at one's egg reserve. 15 to 20 resting follicles would be a good number for most women in their early to mid 30s. How long can you freeze an embryo for? Well, probably at least 10 years. Eggs are probably just about the same. We had somebody recently, it's almost a 12-year-old egg that was starting with the old technology, but the eggs thawed very well and she was able to get pregnant. Here's a question about, does IVF possibly cause borderline ovarian tumors? How much risk is that? The Scandinavian studies are really the best studies we have. They have kind of a captive population and they have data from birth to death. Some of the studies thought there was a slight increase in borderline ovarian tumors, and we're talking about, 2 or 3%. It was less than 5%. So it's really quite low risk. Some of the more recent studies, I think, have not been able to establish much of a increase at all. But again, if you have a IVF procedure, do you monitor more carefully in the future in terms of ovarian tumors? I think that's, with the information we have today, there's no reason not to do that. I don't think it's a general recommendation from the Fertility Society or the OB GYN Society because the incidence is very low, but there may be a very slight increase. Again, we don't know the reason for that. Is it just because of the makeup of the women, although they tried to correct for that in those studies with the general population, but we know that women that struggle to get pregnant also tend to have more other fertility-related issues and medical issues. So it may be genetically who you are that creates problems with getting pregnant in the first place that led you to the IVF. But we can't be too careful about our health in the future. I think there's on the horizon there are going to be many tests that look at gene sequences that may suggest diabetes or autism or other medical conditions. And hopefully there'll be a test in the future to look for ovarian cancer. We certainly know that BRCA1 and BRCA2 genes relate to increased risk of ovarian cancer. There is another germline that was just identified for breast cancer. So I think we're going to continue to see more and more genetic testing that identifies an individual at risk for many different kinds of cancers, whether it's colon or breast or maybe Alzheimer's in the future. So I think there's great hope in the horizon for all of us. Oliver is asking about low sperm count treatments. There may be, depends on the evaluation. Certainly there are specialists, urologists that called andrologists that are the best consultation people for low sperm counts. Sometimes it's what they call a varicocele. Again, that can be treated by ligating that dilated blood vessel. Some men have hormonal issues, and again, stimulating with certain fertility medications may be helpful. Some men with low sperm counts have previous infections in the past. So there are several treatments available for low sperm count, but fertility with low sperm counts is essentially almost cured with IVF, where you can inject a single sperm into the egg. So some men have, a few hundred sperm or a few thousand. The sperm can be identified and injected into the eggs for the partner. JC's asking, and what do you mean when you say genetically balanced? And that's a complex question, a complex answer. But basically, when a woman releases the egg, there's 23 chromosome pairs, half from your mother and half from your father. And as the egg is, just as it's ovulated, those pairs have to pull apart. And half of the genetic code for a given egg goes to the side of the egg to make room for the sperm to come in. Now, sperm are made every day. They're brand new, and they pull apart their DNA really cleanly. However, with age, and we start in the mid-30s, these chromosomes get sticky. And so when they pull apart, the 21 chromosome gets left behind, and that results in Down syndrome. If the 22 or the 16, 15 get left behind, that causes miscarriage. Or if other multiple chromosomes are deleted or duplicated, there is no pregnancy. So the balance is the rearrangement of chromosomes. Now on the chromosomes are 30,000 pieces, and they estimate that there's never been a clone for any of us since the beginning of humanity. So 30,000 gene sequences to the power of 30,000 is essentially an infinite number. So there's no clones for us. We're here, and so we made the cutoff. We were balanced well enough to make it. So there's no perfect embryos. We're all missing pieces or duplicating pieces, but we were good enough to make the cut. So, genetically balanced means the rearrangement of these 30,000 pieces that was good enough to make the cut. Here's another question. What is the minimum number of eggs to freeze? And I have an AMH of 0.5 and age 36. I've had women that have done multiple cycles to get 1 and 2 eggs because they had a very diminished reserve. This one woman, her mother had premature ovarian failure at age 40, and she had the same genetic makeup. And again, with stimulation, she only had 1 or 2 or sometimes 3 eggs that would mature. And so she did multiple cycles, and I think eventually had at least a dozen eggs to freeze. And at age 36, the minimum number you'd like to have, I would think 12 to 15 would be a good number. Sometimes that takes a lot of work. That could be, 2 or 3 cycles. What's the most effective way to get pregnant at age 41? I just saw recently a woman that was 41 that had a basal follicle count of 15 follicles and an AMH that was above 2. It was at a very high range. But if anybody gets pregnant at 41, it's going to be her. But I think it's important if you're late 30s or early 40s to, again, talk to the gynecologist or come to a fertility specialist to do the AMH and to do that basal follicle count and develop a plan exactly what sort of treatment protocol would identify what your egg reserve is, how to be aggressive about finding that genetically balanced egg. But generally at age 41 or over 40, most people are going to be successful with in vitro fertilization, where you stimulate as many eggs as you can. You fertilize them at their optimum with the intracellular sperm injection, and then you grow those embryos to where you can identify the one that is genetically balanced. And again, once you get a genetically balanced embryo, transferring that to the uterus, the pregnancy rate could be 75%. And you may be able to get that balanced embryo in 1 cycle, but it may take, on average, probably 2 IVFs for women in their early 40s. Someone's asked about letrozole and clomid. These are to trick the brain to put out more follicle-stimulating hormone. Sometimes you use clomid in place of, and in addition to injectable FSH, but generally injectable FSH by itself, it gives you the most controlled way to mature eggs. But yes, they can be used in combination with the oral agents in some situations. Somebody was asking here, I'm 42 and to be 43 on Monday. Well, happy birthday a little bit early. And had fibroid surgery in June, so that's about 3 months ago. So the uterus should be healed by then. I think you're asking about the cost of that, and I think someone from the business office can best to tell you about that, because we can certainly get that information for you. How many embryos do couples usually freeze? That depends on age. And again, you're going to freeze all the embryos that you biopsy. You have to wait a week for the genetic report to come back. But again, it depends on your family size and your age. Uh, Many times women are freezing their eggs. They're going to get pregnant on their own fairly easily, and they're using the frozen eggs to thaw when they're 38, 39, or 40 and make embryos at that point. So many times egg freezes are for baby number 2 or number 3. But when you have embryos, again, you know the genetic, you know the potential because they've been genetically tested almost always, not necessarily, but again, if you have a genetically tested embryo, your chance of getting pregnant is 75 to 80%. So most couples, would want to have 2 or 3 genetically balanced embryos to give them a good chance for at least 1, if not 2 children in the future. So Jess is asking about a history of hypothalamic amenorrhea. So the hypothalamus is the brain center that puts out essentially follicle stimulating hormone, or controls that for the pituitary gland. And will that affect IVF success? Generally, if you're not ovulating, most women have a good egg reserve. It depends on their age. But sometimes it's a little tricky to do the stimulation with hypothalamic amenorrhea, but it's a very successful treatment with IVF. And again, the short luteal phase, if you have the history of hypothalamic amenorrhea and ovulating for 15 months, but if you haven't gotten pregnant, I don't know if you've been trying during that period of time, but certainly oral or injectable fertility agents would absolutely be the next step at age 40. Another question, what are the risks of embryos versus egg freezing? I don't know if there's too many risks from the procedure itself, from retrieving the eggs. Bleeding or infection is almost unheard of. It's a very safe procedure. The anesthetic, the propofol, is very safe. You're most safer having that than driving your car to the clinic that day. It's very rare to have any significant complications with that. People ask about how safe is injectable follicle stimulator. Tens of millions of women have taken injections of follicle stimulator for IVF over the past 30 years. And again, the risk of cancer of breast and ovary is really not been determined. This suggestion in one study there might be some ovarian tumors that are of low potential. But I think the studies are very clear. There's no increase in breast cancer. There was a recent study last year that clearly indicated that IVF did not cause problems with breast cancer. So, the concern is that the estrogen gets very high for about a week before the retrieval, but then drops down very quickly. And I think just physiologically and what we know about cell life and development, that the stimulation of cells for that short period of time in a woman's life should not contribute to cancer in the future. So that's certainly the good news. Here's Jen. So I'm 35 and have PCO and go ahead with their options prior to seeking IVF. Well, most women are initially treated with oral agents, either Clomid or Femara, to induce ovulation if you're not ovulating. Even if you're having regular cycles, the oral agents are really the first step before doing IVF. And the recommendation is usually, for young women, 3 to 4 cycles where of treatment with oral agents, where there's monitoring, where you assess the quality of the ovulation. At 35, you're young and obviously you have a very good reserve. And along with the oral agents, we know that intrauterine insemination, IUI, has been shown to improve the pregnancy rates for those oral agent cycles. So the man comes in the day that you're ovulating, and they do what they call a sperm wash to select out the best swimming sperm. And then that little drop of sperm is placed in the uterus. So the sperm about halfway where they need to go to find and fertilize the eggs. And oral agents, either Clomid or Femara, with IUI is really the first treatment option. There's a question about if using a donor, things to look out for CMV, past pregnancies. If you're talking about an egg donor, most egg donors are in their mid to maybe late 20s. They're usually to qualify, be college educated or in college or post-college. They have genetic screening, they have psychologic screening, and certainly selecting a donor, an egg donor that's had a previous cycle is very helpful so that you know how many eggs she usually produces and the number of embryos. That kind of gives you a bit of advantage in how to stimulate that particular donor with the injectable FSH. CMV is not a big issue. CMV is extremely prevalent in humans and does not translate to problems for the child very rarely, but it can be treated with antibiotics. Here's another person asked, does it help to stay on birth control pills when you're trying to increase your follicle? Yeah, the ovary cycles, whether you're on pills or not. We know that women are still having menopause at the same time that they did back in the 50s before birth control pills. So stopping the ovulation does not stop the process of recruiting and sort of the diminution of eggs that occurs no matter whether you're on pills or not. So unfortunately, birth control pills don't preserve fertility in the future. So I hope that answers that question. So another question, I have unexplained recurrent pregnancy loss. If there are other benefits of IVF besides genetic screening for embryos to reduce the chances of recurrent pregnancy loss? Certainly with recurrent pregnancy loss, there's a testing process to look for autoantibodies and other anatomic issues that may contribute to that. But if those tests are normal, I think IVF and genetic screening has been the treatment that gives the very best chance of full-term pregnancy. And I think the studies are very clear that patients in that category do very well with successful pregnancies because you're identifying the genetic issues. And genetics tends to be probably 90% of the reasons for miscarriage. There's a question about how to laparoscopy for endometriosis. Could I get back? How fast does it cut back? It's variable. Endometriosis is that condition where tissue cells that are usually inside the uterus migrate up through the fallopian tubes and start to go around the areas of the pelvis where there's the ovary and the tubes, can cause scar tissue. So the tubes don't pick up the egg. There are also other vasoactive substances and other substances that may interfere with implantation. It generally does not have a big effect on IVF. Once you get the eggs to make the embryos, we usually use markers like CA125 to make sure that it's low. We suppress the endometriosis the month before we would transfer the embryo to the uterus. But endometriosis as a factor does not affect one's eggs or the quality of the genetic quality of the eggs, which is really good news. There's a question here about, am I at the end? Okay, we got through all of them. I don't know if anyone else has any other questions. We're up to just about our hour, which is usual. Those are great questions, and obviously I can tell from the questions there's a lot of concern from individuals about their fertility and which way to go forward. And we're certainly here and available for. We're doing most of our consultations by telemedicine. Be happy to look individually at your particular fertility situation in your life, and develop a plan for you in terms of your future fertility or starting fertility treatments now.